Hello everybody, I am Tipesh Swami. Today I am going to present Paraneoplastic syndromes. Definition: Paraneoplastic syndrome is a disease or a symptom that is a consequence of cancer but not due to the presence of local cancer cells. Paraneoplastic syndrome is mediated through cross-reacting antibodies, production of physiologically active factors, interference with normal metabolic pathways, and idiopathic. Paraneoplastic syndrome classification: endocrine, hormone secreting tumors, neurological, immune mediated, mucocutaneous, hematological, and others. In endocrine part, we could see Cushing syndrome, SIADH, hypoglycemia, hypercalcemia, and carcinoid syndrome. In neurological part, we could see Lambert-Eaton myasthenic syndrome, paraneoplastic cerebellar degeneration, encephalomyelitis, brainstem encephalitis, anti-NMDA encephalitis. In dermatological part, we could see dermatomyositis, lesser trillet sign, Sweet syndrome, pyoderma gangrenosum. In hematological part, we could see polycythemia, anemia, non-bacterial thrombotic endocarditis, and Rosas sign. In others, we could see membranous glomerulonephritis, tumor-induced osteomalacia, and neoplastic fever. In endocrine part, we have Cushing syndrome, ACTH dependent, ACTH independent, primarily adrenocortical tumor, 24 hours urinary free cortisol, and treat the cause. Here we could see moon face, buffalo hump, osteoporosis, muscle wasting is seen, easy bruising, and cardiac hypertrophy and hypertension is seen over here. Endocrine SIADH, syndrome of inappropriate ADH secretion, secretion of aquaporin 2 in apical membrane in distal tubule, increased water absorption, increases urea resorption in collecting ducts, associated with pancreas carcinoma, lymphoma, SCA of head and neck. Clinical plasma hyperosmolality treatment: treat underlying cause, fluid restriction, careful administration of hypotonic saline. Endocrine hypoglycemia, islet cell malignancies, usually after hepatic metastasis, have developed insufficient gluconeogenesis due to the near complete replacement of hepatic parenchyma by tumor. In diagnosis, we could see fasting hypoglycemia, plasma insulin during hypoglycemia, treatment, anti-cancer treatment, glucose, glucagon, and nocturnal meals. In endocrine, we could have hypercalcemia, most common metabolic emergency in cancer. 10 to 20% of cancer patients. Parathyroid hormone related protein binds and activates PTH receptor causing osteoclast differentiation, bone resorption, hypophosphatemia, hypercalciuria. Symptoms of hyperparathyroidism but low PTH, low calcitriol. Calcitriol increases calcium absorption in GIT. Lymphoma, hypercalciuria, low PTH, low calcitriol. Clinical features of hypercalcemia: cardiovascular hypertension, short QT, arrhythmia, and in GIT we could see constipation, vomiting, anorexia, POD, and pancreatitis. And in renal we could see polyuria, polydipsia, neurogenic DI, and renal failure. In rheumatological we could see gout, pseudo-gout. In musculoskeletal we could see weakness, bone pain, and neurological we could see hypotonia, hyperreflexia, myopathy, and coma. Treatment of hypercalcemia: volume expansion plus natriuresis, loop diuretics once, bisphosphonates, inhibition of osteoclast activity, calcitonin, addictive effect with bisphosphates, inhibits osteoclast bone resorption, promotes excretion of calcium and gallium nitrate. Endocrine carcinoid syndrome, Humoral factors producing neuroendocrine tumors 80% from small bowel, greater than 40 secretory products identified. Most important serotonin, histamine, and prostaglandins. Liver metabolysis most so carcinoid syndrome seen most often when liver metastases have developed. Symptoms episodes of flushing, hypotension, tachycardia, secretory diarrhea, and bronchospasm. Carcinoid syndrome diagnosis MRI for tumor localization, somatostatin receptor scintigraphy. Treatment removal of tumor, symptomatic treatment, diarrhea, flushing, antihistamine, octreotide, interferon alpha. Neurological antibodies against antigen on cancer cell across react to antigens on cells of nervous system. Paraneoplastic syndrome can precede cancer diagnosis. Almost all cancer can cause neurological paraneoplastic syndrome. Two general approaches for treatment are remove the antigen and treat the cancer, suppression of immune response. Lambert Eaton myasthenic syndrome. Antibodies against voltage-gated calcium channels causing interference with normal calcium flux required for release of acetylcholine and neuromuscular end plate. Clinically, slow progressive symmetrical proximal muscle weakness of lower limb, autonomic dysfunction, no extraocular muscle weakness or upper limb weakness. LAMS treatment, symptomatic, aminopyridine, immunological therapies, plasma exchange, IV immunoglobulins, oral immunosuppressives, anti-NMDA receptor encephalitis. Greater than 30% children associated with teratoma, 80% good outcome. Clinically, prodromal stage headache, flu-like symptoms, initial symptoms, behavioral changes, secondary symptoms, autonomic dysfunction, hyperventilation, cerebellar ataxia. Treatment, tumor removal, immunosuppressives, steroids, limbic encephalitis. Several antibodies are seen over here, indistinguishable from HHS encephalitis. Subacute onset of seizures, short-term memory loss, confusion, or psychiatric symptoms. CSF, lymphocytosis, rice protein, normal glucose, increased IgG. Treatment, removal of tumor, immunological treatment. Subacute cerebral degeneration. It is T cell immune response associated with SCLC, breast cancer, ovarian, Hodgkin's lymphoma. Rarely no cancer involved. Clinical. Signs similar to peripheral vestibular problem. Severe cerebellar symptoms. Treatment. Aggressive search for cancer. Removal of uterus and ovaries if no tumor found. Immunological treatment is usually unsatisfactory here. Dermatological acanthosis nigricans, thickened organ skin in neck, armpits, and mucous membranes. Gastrointestinal tumors, prostate, breast, or ovarian cancer. Fades when cancer treated. Dermatology, lesser trillet sign. Explosive onset of multiple subarachnoid keratosis and erythematous skin. Gastrointestinal adenocarcinoma, breast, lung, ovary tract cancer, often associated with acanthosis nigricans. Sweet syndrome, acute febrile neutrophilic dermatosis associated with leukemia, acute tender red nodules or plaque are seen, fever, arthralgia, oral lesion, eye involvement. Almost all organs can be involved. Neutrophil mediated withdrawal for TNF and CSF. Prednisolone extremely effective, most immunosuppressive drug. Hematological, hypercoagulability, abnormalities blood composition, increased clotting factor, cancer procoagulant A, tissue factor, cytokines, increased release of plasminogen activator, surgical intervention, chemotherapy, endothelial damage, and prolonged immobilization. Trousers sign, migratory thrombophlebitis, gliomas pancreatic, pulmonary adenocarcinoma, hypercoagulability. Thank you.